All right, welcome to our final chapter, care of the patients with disorders of the urinary system. So we're going to quickly go through this. Here are your objectives. Once again, go through your objectives at the beginning of your chapter, write them down, and answer them as you go through. Also, learn the key terms and look at the key points at the back of your chapter. So, etiology, pathophysiology of cystitis. One of the first things we cover in this chapter is cystitis. There are different types of cystitis that can occur. What is the definition of cystitis? It's the inflammation of the urinary bladder itself. The bladder becomes inflamed. It can become inflamed due to infection, urinary stasis, estrogen depletion, atrophy. Honeymoon cystitis, actually it's more common with urethritis for honeymoon, is also a complication. It results in painful urination, frequent urgent, once again, you get the triad, if you would, the urgency, frequency, and pain on urination. That triad tells you something is up. Low back pain and cloudy urine. Low back pain means it's getting to the kidneys, the ureters in the kidneys, and you could end up with a actual nephritis, an infection of the kidney itself. The cloudy urine tells you, foul smelling, that there's some type of bacterial infection going on. What do you want to get? You want to get a urinalysis, a urine culture. They're always tied together. If the urinalysis is positive, you always get your follow-up urine culture, period. So, what do? We get the labs. Once we find out that it's something that's bacterial in nature, we treat it with antibiotics. Typically, Septra is a very common antibiotic used for urinary tract infections. You might have to use for women that are postmenopausal, you might have to use some estrogen therapy for any type of atrophy that's occurring. Of course, we want to maintain fluid and electrolyte balance because the fluids, large amounts of fluids, will help flush the bacteria out of the bladder itself. So you want to increase fluids. Now, all too often, women with bladder infections, they can get also nauseated and they don't feel like taking in large amounts of fluids. So this is why they get hospitalized, they get IV fluid to help flush that bacteria out of the urinary system. And the antibiotics help treat any bacterial infection. Now, many of you have heard the drink cranberry juice. Now, I'm not going to lie to you. There's some confusion on that. Some people say what it'll do. I'm trying to find where it talks about it. If you look at complementary and alternative therapies on page 790, it'll talk about vitamin C. What it does is it changes the pH balance in the urine. And as such, the acidity of the urine will decrease the amount of cystitis. Because bacteria can only live in a certain pH range. And what you're doing is you're taking the pH to a new range, and you're dropping it to an acidic range, and that bacteria can't thrive in that range. So things like cranberry juice, but orange juice is actually better. And vitamin C has been also shown to boost the immune system. So that's a twofer. So I am a proponent of drinking orange juice on a regular basis. I drink a glass of orange juice almost daily because I just like orange juice. And vitamin C is good for you. And I also take it in through other means. So you can see I'm done with my coffee for today and moving on. Did I mention caffeine is my friend? I might have a slight addiction going, I don't know. So, at the end of the day, that's what cranberry juice does for you. Here's the vitamin C. Boom. I already talked to you about all this. Wow. So this is important for you guys to understand, that there's things you can do proactively at home. So if you are one of those people who's prone to frequent urinary tract infections, these are things you can, and actually German studies have shown that chamomile tea, but that's actually topically, it can help with the anti-inflammatory. I don't know who came up with the idea of putting chamomile tea bags somewhere, but anyhow, I'm a proponent of drinking vitamin C, and so orange juice. Orange juice works good. Urethritis. Now, as I said before, urethritis I mentioned earlier with honeymoon cystitis. Yeah, this is where we get into sexually transmitted diseases and the impact that they can have on the urinary system. Now, sexually transmitted diseases like herpes, gonorrhea, nonspecific urethritis, or all can be acquired through non-protected sex. So if you're going to have mature adult sexual relations, then you need to talk matter of fact to your patients about these things. If you have patients who, have gonorrhea or herpes or any of these sexually transmitted diseases, you have to be matter of fact and almost kind of point blank, and let them know what's available to them. In addition, because that is just a normal part of life, just like childbearing is a normal part of life. But what people don't tell you is when you have a 7 or 8 pound child go through the birth canal, right, that things kind of get stretched out a little, evidently, and that can actually have trauma to the surrounding area, the surrounding muscles, the surrounding tissue, and as such, it can lead to complications with the urinary system. Chemical irritations. Hey, you know what? Mr. Bubbles is not your friend. Bath powders and bath salts and baths in general are not good. Well, think about it. First and foremost, you're sitting in the water, and unless you took a shower before you got in it, chances are the water's dirty. You're sitting in dirty water, right? This is why you shower before you get in a hot tub, so you don't put your dirty butt into a hot tub. At the end of the day, baths and bath powders, feminine hygiene sprays, bubble baths, especially in children, can lead to complications of urethritis. And these are things that you should just avoid, because that urethritis will lead to the triad, the frequency, urgency, and burning, that whole bam. And it can also urethritis can lead to cystitis, which can lead to a nephritis, which can lead to basically a urosepsis. And people get hospitalized with urosepsis all the time, and they die. They die from sepsis, all because it started from a simple urinary tract infection. Believe it or not. People get admitted from nursing homes all the time with urinary tract infections and end up dying. So you need to keep an eye out for any frequency, urgency, burning, but you also need to look for discharge, swelling, inflammation, patient history, and of course, a urinalysis and a culture is your best friend when it comes to laboratory diagnostics. They can pyelonephritis, if it leads to pyelonephritis, which or nephritis as it it can be an acute state or a chronic state, and as such, this is when the infection goes up from, you can start off with something like urethritis, can move on to the bladder, cystitis, it can travel then up the ureters into the kidneys themselves, and you end up with the pyelonephritis, which is an infection of the kidneys. It's typically bacterial in nature. Can anyone think what the most common bacterial organism would be? If you remember from the last lecture, what did we talk about hygiene? We talked about all too often women learn to wipe the wrong direction. And obviously the most common bacteria in fecal matter is E. coli. So E. coli then becomes the most common cause of pyelonephritis or cystitis. It's the most common cause of urinary tract infection, just the close proximity of the fecal matter to the urethra for females and such a short urethra that it can cause problems. Now, these problems include fever, chills, headache, malaise, nausea, all the problems that you're going to come across that you're going to see in your typical infection. But if you look at the continuum, one of the first things you see is the positive SIRS, right? Systemic inflammatory response syndrome. And there's the 4 criteria that we talked about before, time and time again. It's an elevated WBC, an elevated temperature, right? An elevated heart rate, and an elevated respiratory rate. If you have 2 or more that are positive, then you have a positive SIRS. If you have a SIRS, a systemic inflammatory response syndrome, then most likely you have an underlying infection in the patient. This is why we take vital signs on a regular basis. This is how we monitor patients proactively. We understand what the criteria, we understand the continuum of sepsis and how sepsis moves from SIRS, right? Those 4 criteria that I just covered, to an actual infection, which is sepsis itself, because now we have an infection somewhere. And then we move from that to severe sepsis, where the patient has now positive lactates. And we move from severe sepsis, and they continue to get sicker. And they move from severe sepsis to septic shock. And from septic shock, where now their blood pressure is dropping, their heart's failing, they move to organ failure, and finally death. And that is the continuum for SIRS, sepsis, severe sepsis, septic shock, organ failure, death. That is the whole linear continuum of an infection. And that's why it's important for you to understand, so we recognize those signs early in that infection so we can intervene and stop it from getting to organ failure and death. Wow, didn't know you were going to learn all that today, did you? So what do? We look at diagnostic studies. Is this an acute or is this a chronic? What are the signs and symptoms telling us? What is our H&P telling us about this patient? What is their physical assessment telling us? And then what is the underlying diagnostic studies telling us? What is our lab values telling us? What other diagnostic studies can I do? Can I do that KUB? Can I do that CT? Can I do it with contrast so that I can see? You don't have to do IVPs too much anymore. You just do contrast studies with CTs and you can see everything. What can I use? Can I use an ultrasound? Do you know how many stones I've diagnosed with an ultrasound? If you're good with an ultrasound, not only can you see a kidney, you can see kidney stones. So you have to, I know they could see my kidney stone when they did mine. It was a 9mm stone. It was huge. It was like the Rock of Gibraltar in there. But I can tell you right now, there are numerous diagnostic studies that you can do. It's not that you see the stone itself. What you're really seeing is you're seeing that the kidney is enlarged due to the swelling, due to the retained fluid, because the stone is occluding the kidney from draining urine. That's what you have to learn to look for. You start looking for these things. You have to play medical detective. And what you as nurses have to do is you have to assist with that, so we can correct the underlying etiology. If it is a stone, we remove the stone. If it is an infection, we treat the infection. We give the patient the bed rest, the fluids. If they have a fever, we treat the fever with analgesics and antipyretics. If it's, like I said, if it's an infection, we treat it with the appropriate antibiotic. We want to make sure that we're treating. And depending on the type of infection they had, the severity can be tremendous. If someone just had a recent strep throat, I'm going to be concerned that they might have strep, residual strep. Now, what does that do? That's going to cause glomerulonephritis, and we'll talk about that a little bit later. So, glomerulonephritis. Look at that. What's the cause? Group A hemolytic streptococcal infections. So a patient gets a strep throat. A couple weeks later, all of a sudden, their GFR is bottoming out. They're having this urinary system problem, right? Because the autoimmune system, their immune system, is attacking their own kidneys. So what's happening is the strep antibody has actually came into the kidney, and it's now lodged in the Bowman's capsule, and the body's antibodies are thinking it's a strep, and they're attacking the own kidney. So it's an antigen antibody reaction where you have a complex that these deposits are caught up in the glomerulus, and the damage is occurring to the glomule, and you don't get the permeability anymore. Once that cell permeability is damaged, you no longer get that transfusion of the osmosis and the hydrostatic pressure. This is the same thing that happens with COVID-19 in the lungs. You get the lungs that are damaged by the virus, and you lose the permeability, so you don't get the diffusion. If you don't get diffusion, you can't get perfusion, and you can't ventilate. So the patient actually dies of respiratory failure, not because they can't ventilate air into the lungs, it's because they can't diffuse the air that's in the lungs into the bloodstream. And we're ending up here with the same thing occurring in the kidneys, except it's occurring, instead of occurring at the gas state, like it does in the lungs, it's occurring at the fluid state, like it does for osmosis. So it's not diffusion that's happening here, it's osmosis, and we're not getting that permeability that we need. Pretty deep, huh? Now, for those of you who are in 142, we just did a deep dive, but for those of you who are in 240, you guys who watch this for a quick review, that's where you need to understand. That's the level you need to get to in understanding that active transport, right? And that osmotic onconic pressure and that hydrostatic pressure, and how the damage and what that damage can do to those mechanisms. So what do we get? We get a sudden onset, especially with, if it's acute glomerulonephritis. We get the fevers, the chills, the pain. You're going to get widespread edema because the fluid permeability is not there, so the fluid is retained. You're getting fluid retained, what are you going to have? Hypertension. That's right. Blood pressure is going to go up through the roof. Now, look at your urinalysis. What's happening here? What's going on? You look at your BUN, look at your creatinine clearance. That's right. Look at those smoking guns that you know that are your lab values for your urinary renal system. All right. Now, look at your specific gravity. Is your specific gravity? These are simple tests, okay? But the big guns right there are going to be your dead giveaways, your creatinine clearance, and your BUN. If it's getting to the point where your ammonia levels are severe, then people have missed the boat. But the problem is, this happens all the time in nursing homes. You'll see them brought in, and their ammonia levels are through the roof, and they're acting batshit crazy because their ammonia levels are playing on their brain, and they are going crazy, and because they've been neglected for all those early signs. Boom, 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 missed. And who are they missed by? Us, nurses, because nursing homes are called nursing homes for a reason. They're not called doctor homes. They're not called physician homes. They're called nursing homes. They expect us, nurses, to catch those early signs and symptoms and flag it to the provider so that we can intervene and get that patient to where they need to be. And all too often, we neglect that. So what can we do? We then have to start. If the body system can't regulate and do the things, it can't filtrate, it can't regulate, it can't produce, we have to take over those functions for the kidneys temporarily. We might even have to use plasmapheresis to wash away that antigen so that the antibody issue is removed, so that the body's immune system stops attacking their own kidneys. Because if not, it can result in total kidney failure and death. So we have to teach the patient how important low sodium and fluid restriction at this time might be. And I can tell you right now, patients aren't cooperative when it comes to fluid restriction, salt restriction. They don't want to give up their vices. You know, they get addicted to stuff. They like it, man. They just stick with it, period. I don't know. Must be a sign of weakness or something. But, yeah, exactly. So, at the end of the day, we all have our vices, okay? Now, chronic glomerulonephritis. This is the long term, the slow. This happens over time. And unfortunately, it can be a little bit more insidious than acute. Acute, you recognize quickly. The chronic, it's just a headache, hypertension. Now think about it. Can you feel your blood pressure? So how do you know if you have hypertension? You might just start to feel a little fatigue. You might get a little edema, but you don't think much of it. A little loss of body strength, maybe a little irritability. In other words, this can go on. This is easier to miss long term than acute because it's so slow progressing. So what do we have to do? Routine examinations, urinalysis, BUN, CVCs. You do it on a regular basis. You have baselines that you can look at, and now you can got something that you can compare it to, and that's how you that's how you determine whether they're chronic. Does these lab values look the same as the lab values done 6 months ago or 12 months ago? All right. So what happens? Well, when glomerulonephritis, the permeability is increased, you end up with not only this fluid shift, but you end up with this hypoalbuminemia because of the fluid shift. So this proteinuria, hyperlipidemia, hypoalbuminemia, this all leads to severe edema. And as we move on in this chapter, you'll see some, hopefully there'll be some slides on edema and fluid retention, because it's cyclic in nature, as a lot of these things you'll see are. In other words, the one has an impact on the other system, and that has an impact on the other system. So you start this domino effect once the dominoes start to fall. And that's why if we don't intervene, we'll end up in, we can end up not only in renal failure, but we can end up in cardiac failure, respiratory failure, and then finally organ failure. So some of the diets that we might look at is adequate protein, low fat, low sodium diet for any type of nephrotic syndrome. Might look at some diuretics and vitamins and antibiotics. You ought to look at what's the underlying etiology and treat the underlying etiology to keep the physiology within homeostasis. So if you do have an etiology, what is the pathophysiology of that disease process? Is it occurring to both kidneys or just one? So is it unilateral or bilateral? All right. So when there are cases of obstruction, you want to look at what is it that's being obstructed. Okay. And when you have hydronephrosis, for example, that's an obstruction. You have the kidneys, 2 kidneys. Then you have the ureters coming down to the bladder, one bladder, and the one urethra coming out. Now, if all of a sudden the 2 kidneys, you got one that has a huge stone in it, that stone breaks loose and drops into the ureter, blocks the ureter. The kidney's still producing urine. It wants to go down, but it can't. And it's still producing urine. So the kidney starts to swell. because it's gathering the urine now inside the kidney itself. But the kidney is encased. It can only swell so much. So the pressure inside the kidney starts to grow. Well, over time, that pressure is going to start to kill that kidney. So hydronephrosis from a stone can be extremely damaging to a kidney. So therefore, kidney stones can be quite severe. All right. So you got to be careful. If there's an obstruction of the renal pelvis and the ureters, and that kidney can come under a lot of pressure quickly. So yeah, that needs to be resolved. So what would you do? Well, sometimes you might have to go in, obviously remove the stone. Remove the obstruction is the best course of action. If you can't, you might have to go and do a nephrostomy, where you go right into the kidney itself to relieve the pressure. If you have renal stenosis, now that's not the blockage of the ureter. That's a narrowing or a blockage of the artery that's feeding the blood to the kidney. What do you have to have for kidneys to function? Well, it filters the blood. So you obviously have to have blood, but you have to have blood under pressure. So if you have a stenosis, a narrowing of that artery going to the kidney, you have a reduction of blood flow to the kidney. That reduction of blood flow to the kidney screws the whole system up. Because now say you got a normal blood pressure, but you got a reduced blood flow to the kidney. So your blood pressure is 120/80, but the blood going to the kidney is slowed down because of this narrowing or blockage in the renal artery. So the kidney feels like, oh, that pressure is only 90/50. In reality, the pressure is 120/80. So the kidney says, hey, I'm not getting enough pressure here, body. Negative feedback loop, remember? I'm not feeling enough pressure here. I need you to increase the pressure. Okay, we'll increase the pressure. We'll increase the red blood cells. We'll increase through the renin-angiotensin cycle, because we create renin here in the kidneys. Antidiuretic hormone, so we'll hold on to more fluid and do all these things to bump up the pressure. But guess what? The pressure's fine. It's a stenosis. The kidney's not getting the blood because of this narrowing. So the kidneys are being fooled into thinking that they're not getting enough pressure. They're telling the body to raise the pressure. The body does raise the pressure, and now what do you have? You've got high blood pressure. You got hypertension. And the kidney's still not getting enough pressure. And the kidney's like, hey, I told you to raise the pressure, right? It's like, boom. There's no winning. It's just cyclic. The pressure keeps going up. The kidneys keep yelling for more. It's a renal stenosis. So you end up causing this hypertension, and the kidneys end up going into renal failure. So this is a huge problem. How do you check it out? Well, CT with dye will help you, okay, through the blood system to let you see. MRIs can also help, okay, but CTs are more common. You might have to treat the patient with antihypertensives. And down the road, you might have to put a stent in to relieve that stenosis, to solve the problem. We talked about kidney stones before. There are different types of kidney stones. You want to look at what's causing the stone. And if you can figure out what is creating the stone, you can hopefully avoid that in the diet. But stones can cause urinary infections. They can be caused by urinary infections can cause stones. Inadequate fluid intake. That's why we saw them over in Iraq and Afghanistan. You'll see them in these desert environments a lot. Sluggish flow. In other words, you don't get the flow of the urine as quickly, so you get the sediment, which can form into the stones. So you get certain substances in the urine that gather, and they form the nuclei of the stone, and then this calcification keeps occurring over and over it, and much like a pearl, it grows, much like a pearl will grow inside an oyster, a stone will grow inside a kidney. Except, I don't think anybody looks at kidney stones quite the same way they look at pearls. Kidney stones, well, unfortunately for men, you got a higher incidence. This is one of the, let's face it, men on most of these aging don't do as well as women. We just don't. We don't age as well as women across the board. Family history. Let's see, I've had kidney stones. My brothers had kidney stones. My other brothers had kidney stones. I don't think there's a single person in my family that hasn't had a kidney stone. It's very familial in its nature. So if they run in your family, lucky you. Like I said time and time again, I didn't get this haircut from my dad just because I was lucky. Genetics are what they are. But there are some things that you can do. Diet does have an impact. And as I said before, Mediterranean diet will help decrease the formation of stones. Obesity, being overweight has a history. Of course, actually anti-cholesterol medication. Being on anti-cholesterol medication puts you at higher risk for some certain types of stones. So you have to understand that these things can cause. And once you have a history of, just like urinary tract infections, once you get a history of it, you usually have it more than once. Pain, nausea, vomiting. When I say pain, I mean pain like you cannot imagine pain. I'm here to tell you, I can't explain how much pain a kidney stone can inflict upon you. I have been cut. I've broken my ankles on jumps. I've dislocated my shoulder. I've had my shoulder my bicep tendon surgically reattached to my shoulder. I've experienced some trauma in my life. None of it compared to the pain I felt from a single kidney stone. It dropped me like I was a baby. I mean, it's so understand if you work in the ER and someone comes in with kidney stones, much like if someone, when someone comes in with a migraine headache, you don't, you just take it for face value that these people are in pain and you need to treat their pain immediately. That's the first and foremost thing to do is establish IVs in both cases. So you don't really need to wait to get your tests back to see if they have a kidney stone. Treat the pain. Pain management is the key. Antispasmodics can help, but nothing quite helps like opioids. Now, if you don't like drug-seeking behavior, there are Toradol has had actually pretty decent studies. There are other things you can do, but number one thing you need to do is they need to get in and get that stone taken out. The sooner they get rid of the stone, the sooner they get rid of the pain. That's the truth of it. All right, what do we do? Manage the stones. Increase your fluids. Try to prevent stones from gathering in the future. Look at their risk factors. Look at their history. They might need a stent temporarily. I had a stent placed when I was in Afghanistan. The stent goes from the kidney all the way down. It's like a wire loop, and it goes all the way into the bladder. And it just keeps the ureter open. That's all the stent does. They're temporary, and they are removed later on. Now, trauma to the kidneys. Here's something we have to remember. We said these kidneys are extremely vascular. Remember, in the anatomy class, they almost have direct lines to major blood vessels. So any trauma to the kidney can lead to hypovolemic shock. You can bleed to death by trauma to a kidney. So kidney laceration. Kidneys can become detached and break off because of sudden deceleration. So this was very common in jump injuries where the parachutes might have only been partially opened and they hit the ground with huge force. They either detach their kidneys, poof, or their heart is another area where they their heart tears away and they get a separation from their aorta. So those are deceleration injuries from falling from high altitudes. The internal organs, boom, are pulled, dropped, and they actually rip away from the blood vessels, and the patient bleeds internally. So that's sudden deceleration. All right. Penetrating trauma can occur, minor contusions, hemorrhaging, and of course it can result in that hypovolemic. We talked about that can result then in the flank pain if they are bleeding. It can have some ecchymosis, flank, the bruising. You might see bruising around the umbilicus. Bruising around the belly button is an indication of a retroperitoneal bleed. And you have to be cognizant of that if I've got bruising around the belly button, I might want to think that they might have something going on retroperitoneal. Obviously, you have various studies at your disposal, CT being one of the most, I would say, probably your fastest and the one that's going to give you the most information right out of the gate. I do like ultrasound for fast exams. They are very productive and they have their place, but nothing works quite as effective as a CT. All right, treatment and nursing care of trauma to the kidneys. Well, hopefully it'll be self-limiting in nature. If not, they're going to need surgery. That's just the bottom line. It either is or it isn't. Now, how do you know? Well, a lot of times you have to monitor, and you just wait and see. But sometimes those CTs, especially with dye, will tell you. You have to look. Do I have signs, symptoms of shock? Is this patient becoming hypovolemic? Are they tachycardic? What are my early signs and symptoms? What is my urine output? What is my patient telling me? What is their clinical picture demonstrating? How bad is this damage? And you monitor all these things. You place a Foley catheter. Do I have blood in my urine? Do I have urine output? Is my patient stable? And if they are, good. You're going to observe them for 24, 48 hours. If they're not, then they might have to go straight to surgery. So, how do you diagnose it? Well, what's the mechanism of injury? Did they suffer a violent blow, trauma, crushing injury? Do you have the triad? Is there frequency, urgency, painful urination? Are they creating urine? What is my overall baseline? And then what you do baseline, but then you do follow-on labs to compare to your baseline. You do a physical assessment, then you do a follow-on physical assessment. Are there any changes from my baseline physical assessment? Is there bruising where there was not bruising before? Is there a mass where there was not a mass before? Is there tenderness where there was not tenderness before? You have to do all this up front. That's why it's important to get these baselines early in your patient so that you can do the comparison, okay? And that's important. You have to look, do I have gross hematuria? Do I have suprapubic pain? All right. And what do my diagnostic studies show me? And it's important for you to understand because doctors miss things and nurses catch things for them all the time. So it's important for you to have a grasp and an understanding of just the minimum of what that means. All right. Cancer of the bladder. Now, cancer of the bladder does occur. All tumors of the bladder are cancer. This is something as you well know, my wife and I just went through. My wife just had cancer of the bladder. It's more frequency. The frequency is usually in smokers. Now, she hasn't smoked for over 20 years. Usually urban areas. The key to diagnosing bladder cancer early is noticing the hematuria. If you detect the blood in the urine early, blood in the urine is not normal and should always be followed up. Luckily, she had a PA that did insist on the proper diagnostic. She went to the doctor the first time, and the doctor's like, oh, don't worry. And a couple months later, she went to the PA. And it was the PA, that, not the doctor, that caught the blood. You know, the doctor was like, oh, you know, well, that happens sometimes. You know, maybe it's just, you know, a female thing, you know, and blew it off. And the PA is like, well, you know, and a lot of times those mid-level providers are more cautious because they're like, well, you know, I'm not going to lie, as a nurse practitioner myself, I was like, I'd rather be safe than sorry. You know, I'd rather, you know, I'm not paying for this diagnostic test. So I'm going to order it and make sure, you know, where these doctors are like, well, they know the statistical odds. So they're like, she didn't fit the normal clinical picture. She hadn't been smoking in, you know, over 20 years. We're not living in, you know, no occupational exposure. She didn't fit the proper picture for that doctor. So her doctor's like, oh, chances of it being cancer, you know, my wife, but it was persistent. My wife went back and saw the PA the next time. The PA's like, oh, well, that makes me uncomfortable, so I'm going to order this test. And sure enough, she ended up with a stage 2 bladder cancer. And what did they end up doing? Well, what did I tell you they do? I told you 3 things. To cut is to cure. They always remove the cancer, cut it out. Okay, radiation therapy. Now she didn't need that, or chemotherapy. They can do bladder washes with chemotherapy. And it's actually an interesting technique. What they do with the bladder wash isn't so much a chemotherapy as it is it's actually a bovine tuberculosis that is introduced into the bladder wash, and then it becomes an antigen antibody, and it creates your body attacking the lining on the inside of the bladder and destroying any potential cancer cells. So they have your body's immune system attack your own body's cells to destroy any potential cancer cells. Pretty interesting technique when you think about it. So, as I said before, what we do, they can go in and remove. But all tumors of the bladder are cancer. I didn't know that until this happened with my wife, and Dr. Bohm explained that. He's like, hey, the minute he said, because I was like, well, are you going to biopsy it? He's like, well, it's definitely cancer. All tumors of the bladder are cancer. You might need urinary diversion, which can sometimes result in an ileal conduit, an ureterostomy, or a sigmoid conduit. You might end up with an ileal reservoir or cock pouch, which you've seen in previous classes. Obviously, smoking cessation, I think we've kicked this horse. It's pretty dead. All right, so we want to make sure that our patients quit smoking. And one of the best ways to do that is to lead by example. So if you're a smoker, stop. It's just that simple. All right, acute renal failure, sudden onset. Now, you can have acute renal failure from injury, infection, inflammation. One of the big ones is injury, right? Burns. Burns can lead to renal failure. Trauma can lead to renal failure. You ask yourself, well, how? Hypovolemia. You have to have the hydrostatic pressure for kidneys to work. If you don't have the fluid status, you don't have the hydrostatic pressure. You have to have fluid to have fluid pressure. So if the tank isn't full, you can't have pressure behind the tank. And without pressure, kidneys don't work. So you can have acute renal failure. You can have pre-renal failure with acute renal failure, which is a decreased blood flow to the kidneys, as we talked about renal stenosis. You can have intra-renal failure and acute renal failure, which is the damage to the glomurule, right, like glomerulonephritis. You can have post-renal acute renal failure, which is an obstruction in the ureters, like a kidney stone. These are all the causes of acute renal failure. So what do? When we have acute renal failure, we're going to have changes in our urine output. We're going to have electrolyte imbalances, fluid imbalances, acid-base imbalances, all the things that the kidneys do for us. We're going to have a change in mental status because those metabolites, those waste products that are normally filtered out of the kidneys, aren't being filtered out. So they're rising. You get a rising ammonia levels. You get anemia because the kidneys aren't telling the body to produce the proper amount of blood. You get all this, boom, domino effect that's occurring because the kidneys aren't working, and how the systems impact systems. This is why when an organ fails, you go into multi-organ failure, because when one system shuts down, the next system, then the next system, then the next system. So we have to look at the changes in the urine output. We have to look at the electrolyte balance, and we have to fix it. We have to temporarily take over the kidney's function, and we have to eliminate. We can do this through things like dialysis. We can do it through peritoneal dialysis, or we can do it through hemodialysis. Those are the two types of dialysis that we can use. So we can filter out the metabolic waste. We can regulate the electrolytes. We can take over the kidney's functions temporarily. And we do it all the time. You see patients come in for hemodialysis on a regular basis, okay? But we're just going to do this temporarily for acute renal failure. So these guys already know all the lab values and the diagnostic studies that you can do, okay? So we have to treat these patients. What do we do for chronic renal failure when it's long-term? Acute renal failure, hopefully the person gets over that acute event, and we get them over the hump, and the kidneys start working again. And boom, dodge that bullet, right? But what happens when it's this insidious long-term kidney failure? And you get this long-term chronic kidney failure that occurs in stages. Now, Google the 5 stages of kidney failure and your glomerular filtration rate. Google that. You'll find that your GFR, if your glomerular filtration rate, and I like to think of it as, because you have stage 1 kidney failure, stage 2, stage 3, stage 4, and stage 5, right? So as you progressively get worse, your glomerular filtration rate progressively goes down. So if your GFR is like 0, less than 15, you're stage 5, right? If it's 30 to 15, stage 4. If your GFR is 60 to 30, you're stage 3. If your GFR is 60 to 90, you're stage 2. And if you're better than 90, you're stage 1, which is your normal, right? So that's how I like to think. I like to think, you know, my kidney is 5 stages, 1, 2, 3, 4, 5. Then I think of groups of kind of like 15 and 30. Less than 15 puts me at stage 5, kidney failure. Boom, I need 100% dialysis at this level. Okay, less than 30, that's another 15, is stage 4. This is where most people realize they need. Okay, 30 to 60 is stage 3. This is where, between stage 3 and stage 4, is where people realize they have kidney failure. Stage 3, okay, they don't even know they have kidney failure yet. Stage 4 is, like I said, is usually between 60 and 90. That could be you. That could be me. Not even know it. It's not until I get to between stage 3, transitioning to stage 4, kidney failure, that I even begin to realize I need dialysis, where symptoms start to appear. That's huge. And when I get to stage 5, I need dialysis. So that's huge. Understand those. Understand how they work. Google it. All right. So you might find yourself on dialysis. So you might find yourself with a shunt, an AV shunt, right? The blood moving through this, and what do we do when we're doing that for the hemodialysis. And when you look at the, I'm trying to find the page where it's showing it. I don't see it in my book. Oh, there it is. Well, that graph has to be put in place. And when you have it, you are going to look at that AV fistula, right? That fistula that's going to shunt the blood from the artery directly to the vein, bypassing the whole capillary bed. That means you're going to get all this, you can feel it. You'll feel it. When you feel it, remember, you're going to feel the vibration of it, this fistula. That vibration is called a thrill. You feel a thrill. You auscultate it, you listen to it with your stethoscope, and you'll hear the rushing turbulence of the blood from the artery to the vein. That's called a bruit. That's called a bruit. You hear a bruit. You feel a thrill. Okay? That's important to understand. Now what it does is you're taking the blood, the dirty blood, out of the patient. You're running it through the machine. The machine filters the blood. It regulates the electrolytes. It does what the kidneys are supposed to do. And then it takes and it pumps the clean blood back into the body, and then it goes into the vein. So that's what all you're doing with dialysis. Now, peritoneal dialysis is similar in the sense that you're putting the fluid into the peritoneum, okay, and you let the fluid sit for hours. And then you lay the bag down and you let it drain out. And through the process of osmosis in the abdomen, it removes all the metabolic waste. And peritoneal dialysis works great. Does a wonderful job. But all too often, people don't like it because they're doing it themselves. They're not doing it. You're not going to a clinic and having it done for you. And not all patients are candidates for peritoneal dialysis. So understand, hemodialysis has complications of fluid overload, electrolyte imbalances, alteration in blood components, and obviously bleeding tendencies, especially immediately following the dialysis. You are required to have an arterial ventricle shunt or fistula put in place. And as I said before, you feel the thrill, you palpate the thrill, you listen, you auscultate for the bruit. You can never use a manual blood pressure on the arm or extremity that has an AV fistula. Doing so can damage the fistula and cause severe damage. Now, peritoneal dialysis. Peritoneal dialysis has advantages. It can be started more quickly. Don't have to worry about anticoagulants, so you don't have as much bleeding tendencies. No IV access is needed. It's less stressful. It's a gentler therapy. There's less trauma. There's less violent swings, okay, of the body's homeostasis. It can be done while you sleep. However, there are some complications of fluid overload, obstruction, and obviously peritonitis could be a major complication. Okay, eventually the patient might require a kidney transplant. when the diseased kidney is removed, the new kidney is not placed where the old kidney was. Instead, the new kidney is actually placed down, the donor kidney is placed down in the pelvic girdle, if you would, and as you can feel your own pelvis, your iliac crest, it'll be placed inside the cup of the iliac crest, right there. And obviously that's for easier attachment to the blood vessels. Also, it's so that the kidney can be in a stable location and be protected. So who decides who gets the kidneys? Well, typically speaking, it's state laws. State laws determine how organ transplants work as a whole. And if you work in an emergency room, you actually have to take classes on organ donations so that you understand what to do for organ donors in the event of a fatality. Once they have, if the patient is experiencing any type of renal failure, obviously dietary restrictions are going to be important. You want to try to minimize certain metabolites forming in the body, and it's going to be important for the patient to take in certain proteins. So that's going to a dietary nutritionist is going to become an important part of any person who's in chronic renal failure. This is very common in diabetics. So you have to understand that diabetics going into chronic renal failure is common, and as such, diabetics needing dietary education is critical in order to maintain that tight glycemic index. And that's what's crucial for diabetics and the health and welfare of a diabetic patient. So this pretty much, ties up the class on the urinary system and disorders of the urinary system. I hope these recorded classes have worked for you. I'll be seeing you. I'll post them today, and I'll be talking to you all tomorrow online. And then we will prepare for the final exam, and I will put your test dates out accordingly over the next several weeks between now and the end of the semester. How we move forward from here during these trying times, I don't know. I don't have the answers, but we will get through this together. You guys have a wonderful day, and remember to send me that email on 24-hour urine test if you want credit if you're in nursing 142. So take care.